The drones are ubiquitous. There are thousands of drones in the sky every day. If it can be seen, it can be killed, is kind of what the guys are saying. And the fiber optic controlled drones are now going out 40, 50 kilometers. So the red zone, the kill zone, extends 40 kilometers deep to the front line.
Enter the world of military trauma surgery with Frontline Surgery, where we bring you expert insights and real-world scenarios to help surgeons stay ready.
Brought to you by the AAST Military Committee. Join us as we engage in conversations with field experts, examine critical battlefield scenarios, and uncover the strategies that keep surgeons ready for anything.
Stay prepared and stay sharp with Frontline Surgery, where every episode provides key insights into mastering military trauma care. All right, welcome to Frontline Surgery, Mastering Military Trauma Care. Again, my name is Joshua Dilday. I'm joined with my co-moderator. We've done a couple episodes now. I'm joined with Jeff Conner. Jeff, how are you doing today?
Good, excited to be here. I think we got a great episode today, but it's always good to be back on the pod with you, Josh.
Yeah, no, it's right back at you. And I'm excited for this episode. You know, this series to adjust the framework of the series, it's designed to prepare that early career military surgeon for the evolving realities of deployed trauma care. And today's episode, what Jeff alluded to, focuses on blast injury and the emerging injury patterns associated with modern drone warfare. And unfortunately, this is becoming an increasingly dominant threat, and especially the large-scale combat operations, which we're seeing in the shifting geopolitical climate that's affecting us today. This battlefield's changing rapidly, and so are the mechanisms, and we have to be prepared to manage those wounds and those patients that are going to come in. And because of that, we've reached out to a repeat guest, an expert in the field, Dr. John Holcomb, who has both firsthand experience in treating these casualties and provides a system levels perspective on how these injuries are reshaping modern military care. Dr. Holcomb, thank you so much for joining us again on Frontline Surgery.
Yeah, it's great to be here. Thank you very much. Just for the group out there, anytime Josh and Jeff ask me to do something, I say yes.
Well, thank you. We ask you as often as we can because you're an expert and you've been a mentor to both of us. And specifically on this topic, can you kind of tell us what you've been doing recently in the realm of some of these injuries, whether it's drone warfare or some of these blast or explosion type injuries?
You know, guys, there's a group of us have been in Ukraine and in Poland many, many times. And as you all know, active duty guys can't go to Ukraine, which is unfortunate in some respects. And so early in the war, 4 years ago, actually today, got a call from some friends that were there. And they asked, said, hey, can you send us over some PowerPoint slides about resuscitation? And I said, well, of course. And a couple of days later, they said, why don't you just come over and tell us about resuscitation? And my wife said it was okay. So I went and worked in Western Ukraine, taking care of combat casualties. And then subsequently have been back in Ukraine 4 other times, so a total of 5 over the last 4 years of all-out war. And probably more importantly, however, is we've had now 17 1.5-day symposia in Warsaw where we bring Ukrainians out, bring U.S., NATO, and U.K. Folks together for a day and a half, very focused, trauma systems, mental health and providers, drones, et cetera, that kind of thing. 17 of those over the past 3 years, about every other month.
Well, Dr. Holcomb, that's incredible. I know that we, in the military have used some of the things that, from what you have seen and talked about at some of these conferences have given us really great insight into what future wars, involving the U.S. may look like as well. Before we get started, I wanted to kind of run just a scenario to kind of set the stage for our talk today. Okay, so it's a late afternoon. You're at a Roll 2 facility supporting forces in a contested environment. A small unmanned drone detonates over a patrol environment, dispersing fragments in a wide radius. And within minutes, you've got multiple casualties arriving with penetrating injuries to the head, neck, upper torso, with many small, high-velocity fragment wounds that are deceptively subtle on exam. Several have altered mental status without obvious signs of hemorrhage, and your evacuation is delayed due to continued drone surveillance overhead. So just hearing that, what immediately kind of stands out to you in this scenario, and how does this differ, or how does it differ from some of the blast injuries or some of the scenarios, the situations that we have dealt with in the past, maybe let's say in the Middle East?
Yeah, Jeff, thanks. Number one, I just got to say blast is like saying Xerox for all copiers, right? It's a slang phrase, and it's become uh, almost part of doctrine, right? I mean, it's everywhere. As you guys know, there's primary, secondary, tertiary, and quaternary blasts, and some people even include a fifth part of that. But the bottom line is open space explosions, which is the technically correct term, usually don't have a blast overpressure injury. If you're close enough to an explosion where you would get that blast overpressure wave, you're usually shredded and literally blown to pieces. Now, that's true with a 155 shell, which was the typical explosion in Iraq and Afghanistan. These are usually smaller explosions from the drones at this phase of the war. Not earlier where there are tanks and artillery warfare, but now the drones, usually smaller. You have to be really close to that one of those explosions to see the blast overpressure wave. It goes up very high and down very, very quickly when you plot that on the graph. That's been well described by the U.S. military since the end of World War II. In Korea, a lot of experiments were done that documented this very nicely. So in that scenario, which is all too common, you have to be aware of blast overpressure. You have to be aware of fragment injury. And you want to try to find out pretty quickly, was this an open space explosion or a closed space? Did the drone fly into an underground area or a trench where that blast wave would have reverberated back and forth like we all learned in high school physics? The injuries that the Ukrainians are reported are different than what we saw in Iraq and Afghanistan, where predominantly saw lower extremity, chest out and pelvis, and not minimizing the brain and tympanic membrane and that sort of thing, but less common. Those injuries, because they now come from above, are very common on the Ukrainian battlefield when the Ukrainians are reporting injury patterns. I would say that because of the proliferation of electronic warfare in all forms, our Ukrainian colleagues are loath to present numerators and denominators. They're loath to present exact wounding patterns from exact munitions, right? Because that informs enemy who may be listening to this podcast as we speak, the better ways to hurt Ukrainians. And so they're not going to do that, and nor am I. I don't know that, and if I did, I wouldn't repeat it. But they have clearly said that injuries are coming from above. There's more head, there's more tympanic membrane, there's more eyes and neck and upper extremities. Lower extremity injuries are still very common, right? If you think about it, depends on the orientation of the soldier when they're hit by the hand grenade or mortar that falls from the sky. If they're standing upright, you have one injury pattern. If they're in a trench and laying flat, there's a different injury pattern, right? I mean, it kind of makes sense. So when people say, what injuries do we need to be aware of? I would say all of them, right? If I was a young surgeon or a young clinician, medic, doc, nurse to go to the battlefield today, it's my impression, having been in Ukraine multiple times and talking to lots of people, that every weapon in the arsenal is being used on the battlefield short of nuclear weapons. Right? That's a pretty sobering statement, actually. But if I was in y'all's shoes, I would read and prepare for every injury.
Absolutely. Something that you mentioned already a couple times, which I had a chance to talk to some of the Ukrainians out at UNC last year. What I didn't really think about as the trauma surgeon, always thinking about vascular injuries and penetrating injuries, was the tympanic membrane injury. And they really focused on talking about that. How are they managing that, downrange, or is that something that ENT is managing? How is the deployed trauma surgeon managing that?
We wrote about that, Jeff, in Iraq and Afghanistan, and wrote some papers early on just about this. So fortunately, there's not much that needs to be done at I'll call it forward surgery team because I'm old, right? That's what we used to call it. There's not much you need to do other than, I think, diagnose it, right? Small tympanic membrane injuries heal on their own. Large tympanic membranes, 25% or more of the TM, probably need 25 to 50% probably need some kind of tympanoplasty. Obviously not done by general trauma surgeons, done by ENTs folks back in the rear to restore their hearing somewhat to normal. I think the key is diagnosing the problem. And it reflects that blast overpressure. So when you do see a tympanic membrane rupture, then you need to go looking for other injuries, lung and bowel.
And that's a great point because that comes up in the JTS guidelines, is that we should be screening all our TBIs for tympanic memory. So that's something that we've identified from the coin era and before, and now we're seeing again even more in Lisco, but for a different environment, and it's drones. And you talked about the anatomic differences. What makes taking care of these patients in the drone injury era so difficult? Is it
You
just the
know,
injury, or is there more to it?
yeah, it's a great question, Josh. Let's go back to the tympanic membrane thing for just a second. Mild TBI and PTSD are really hard to differentiate. This is why you have to know where they were in relation to the explosion. You have to know what kind, if you can, what kind of munition went off, and then where there's an open space or closed space. And that really tells you what injury to go for. It's kind of like the guy who falls off a 3-story building and lands on his heels. You go looking for about 5 other injuries, right? We're all taught that in residency. Oh, by the way, we talked about it last week when I was at rounding. And you go find those injuries. And sometimes they're subtle. So knowing the mechanism, if you will, of the injury and the injury patterns that are associated with a certain mechanism is really important. I honestly don't think this individual injuries are any different. A fragment through the brain, the TM through the neck from a drone is like a fragment from an IED coming up and going through the eye, the brain, the neck that we all took care of in Iraq and Afghanistan. So the individual injuries are the same. I will tell you that the first time you see an explosion patient with 100 holes, I don't know about you, but it knocked me back. Right. In the civilian world, you see a guy with 1, 2, 3, 4. We talk about the guy with 10 holes, but these soldiers, sailors, airmen, Marines have 100 holes. And each one has to be treated, almost separately. You have to go look for the injury underneath.
Wow. Wow.
That 100 hole thing, I think, is really important. And every time you deploy, it takes you a while to readjust to a soldier with 100 holes. Usually, in my experience, the team needs about 2 weeks to switch over from civilian trauma to military trauma. And it's that guy with 100 holes. Or, as you said, Jeff, 4 or 5 of them with 100 holes all at once.
So I guess kind of changing gears a little bit more, maybe on the team-based approach, system-based approach. What are some of the, I mean, this goes without saying, there are increased operational challenges in the drone-dominated environments. But how does that change, your stabilization, your resuscitation time frame? Does it just depend, or what are some of the things that you've seen, or heard about in Ukraine that they're dealing with now?
Yeah, Jeff, it's not a great story. The drones are ubiquitous. There are thousands of drones in the sky every day. If it can be seen, it can be killed, is kind of what the guys are saying. And the fiber optic controlled drones are now going out 40, 50 kilometers. So the red zone, the kill zone, extends 40 kilometers away from deep to the front line. Hemorrhagic shock patients, with the evacuation timelines of anywhere from 2 to 12 hours, 2 on a really good day, 12 on a normal day, and way longer days on much longer. The guys in hemorrhagic shock are not making it back to the surgical facilities. It's, we've worked with the Ukrainian MOD. We've worked with folks on the front lines. The KIA rate triples. KIA rate triples. Case fatality rate skyrockets. And, we talked rapid evacuations, which we were used to, does happen. There are patients who come back in hemorrhagic shock, but it's not going to be like at least what the Ukrainians are seeing because of the drones and the lack of air superiority, which has been well discussed. Drones have really changed that so much. I was in Ukraine and Kyiv at a tourniquet symposium in November of this year, and the quote was thousands of casualties evacuated by ground drones, thousands. That's the first time I've heard that number. A year and a half ago, we had a symposium that talked about drones, and it was 1 or 2. But a very senior person said thousands by ground drones, which
Wow.
takes hours. So, I mean, just think about that compared to when I deployed, which is a long time ago, guys would come, within 30 minutes right off the battlefield. And that is not happening. So, physiology has not changed. Hemorrhagic shock has not changed. And timelines of death have not changed. What's changed is the drones.
So, aside from having to hold these patients, these soldiers, longer in that type of scenario, I imagine the supply chain to your surgical team is reduced or non-existent in some cases. How, I mean, are you seeing ways of resource mitigation or allocation or optimization from just a consumable resources?
Yeah, we have, I did a GMO year in northern Turkey in 1986 and operated in as a GMO, went down and operated with some Turkish colleagues who reused disposable gloves, who reused gauze, reused lap pads. Um, if I was doing this again, I don't know, frontline and supply is an issue. What is an issue, as you said, things that are disposable in our world back here in the United States become reusable when you're out and about. It's not just in combat. I mean, it's many places around the world, and that kind of mentality, I think, is it's almost a frame shift for most of our guys and gals.
Dr. Holcomb, you mentioned the 100 holes versus the 10 holes and really, really highlighted the difference between deployed, austere, expeditionary surgery and then what we see stateside. As a lot of the military trauma surgeons are coming from these MILSIF partnerships and integration and at least CONUS-based hospital systems, what should the future deployable surgeon be doing? You mentioned focus on every injury, but can you break that down a little bit? I mean, how does one in an environment that seems otherworldly prepare to be the surgical leader on the front lines in the very near future?
Josh, I honestly think it's a very simple answer, and all I know is my personal experience. I trained at a place, William Beaumont, El Paso, Texas. Not a lot of high fancy medicine was done there, but we did a lot of surgery. And then I went to Fort Bragg, and at that time I mean, we did just about everything. I honestly think that in training to prepare to go to the battlefield, that this crawl, walk, run, sprint paradigm that people talk about all the time, right? To me, the sprint is deployed combat casualty care. That's the sprint. It's not easy. It requires a frame shift from a run, right? But the run, in my opinion, is at our MILSIV partnerships. That's the run. I've been back to multiple MTFs to visit. And outside of one, right, the MTFs are not busy and there's not a lot of running going on. Now, I've worked for the past 6 years in a MILSIV partnership in Alabama. You guys both work at MILSIV partnerships right now. When you're on call, you're running. I mean, literally, not just figuratively, but literally. When you're on trauma call. That is the best preparation today for going downrange and sprinting. No question in my mind.
That's excellent. I mean, we both obviously support the military civilian partnership and all the opportunities for the military engagement from the community, whether that's being trained in MTF or partnerships in whatever fit form or fashion. But I think that incorporating some of that running in those training environments is key to make sure that you can hit that sprint as fast as you can when you get in that environment. Well, Dr. Holcomb, this was phenomenal. We had no expectation other than the fact that it was going to be phenomenal because we know what it's like for you to be a repeat guest on us. And for those listeners, we hope today was informative. Jeff, I think that this episode is just quite alarming. And we knew it would be, but it seems like every episode we do, especially as we start going into multiple seasons, the realities become more and more scary. I don't know what you're thinking where you are, but it's a reality that we're not excited about facing, but we have a duty to do so.
I totally agree. I love what you said, Dr. Holcomb, about the walk, run, sprint. I don't think that and we're fortunate, there is nowhere in the U.S. that we have to sprint and deal with hundreds and hundreds of holes and hundreds of patients. That's a good thing, right? However, we've got to be prepared to handle that in the battlefield. And like you said, at some of these military civilian partnerships, I also agree. I think that's the answer. So I appreciate you saying that. I appreciate all of your wisdom through this talk. It was great again. And thanks for coming on.
Well, there you go. Dr. Holcomb, thank you so much for joining us here on Frontline Surgery, Mastering Military Trauma Care. Again, modern drone warfare is redefining the injury patterns that we see on the battlefield. You talked about the injury patterns, the anatomic differences, the resource allocation, the logistical issues, and you talked about how to prepare, that we must evolve and fight and treat take care of patients and that being able to run as quickly as we can.
Okay, Josh, can we make one last comment? One last comment?
The mic is yours. Go ahead, sir.
I'm sorry to interrupt you. We've talked a lot about surgeons, but it goes without saying that the team has to be ready to sprint, right? The team, the nurses, the medics, the CRNAs, the anesthesia. I mean, the whole team, right? The emergency medicine guys have to be ready to sprint. I know it has to be said. It goes without saying, but it has to be said. The team is important.
I'm glad you hit on that. And I think that's a phenomenal point to end on. This is a team. It takes an entire team to take care of these patients, especially in the evolving battlefield. And with that, I don't think we have anything else to say, Jeff, except we'll end the way we end every podcast is stay sharp and stay ready. Thank you so much. We'll tune in next time.
Thanks,
See you guys.
Thank you for tuning into this episode of Frontline Surgery. We hope today's discussion has provided valuable insights into military trauma care.
Be sure to join us next time for more expert perspectives and battlefield-ready knowledge. Until then, stay ready.